Good morning, everyone. In this quality improvement case study, we will learn how the pediatric emergency team implemented the science of improvement to reduce the incidence of phlebitis and infiltration. The project was carried out successfully and was published in Indian Journal of Critical Care Medicine. The aim was to reduce the incidence of phlebitis and infiltration by 50% over 2 months among children admitted to emergency room of a tertiary care hospital. Let us look at the learning objectives. At the end of session, learners will be able to appreciate how pre-assessment findings are utilized to construct a fishbone diagram, identify how the root cause of problem is identified using fishbone diagram, prioritize intervention or change using Eisenhower box, conduct plan do study at cycle, decide, adapt, adopt or abandon the change. Pediatric emergency generally have high patient load, low nurse-patient ratio and limited resources, especially in low-middle income countries. This leads to poor adherence to aseptic techniques and higher incidence of phlebitis and infiltration. Literature search and further reading suggested that aseptic non-touch technique is a critical strategy to reduce infection in hospital setup. In addition, quality improvement initiatives, audit assessment, and feedback of healthcare professionals, organizational change, and reminder system using variety of methods and education of patients and healthcare professionals are other key strategies to improve the services. A team consisting of bedside nurses, nurse educator, administrative in charge of the unit, and residents was formed, and a specific roles were assigned to each team member. The team tried to prepare a fishbone diagram. This diagram, as we can see in the slide, is a visualization tool for categorizing the root cause of a problem. It combines the practice of brainstorming with the type of mind map template. Few causes were striking in the fishbone diagram as demarcated in red color. Under person, healthcare professionals in emergency area were always in hurry given the low nurse-patient ratio, and since there was no separate recognition between a good performer versus others, there was a general lack of motivation for taking additional efforts. In material, the sterile trays or packs were limited, the supply of sterilium was not adequate, most of the patients admitted were poor and it was difficult for them to buy this material. Under policies and procedures, the syringes, sets, cannulation sampling articles were kept on cardiac tables, trolleys or bed. No specific tools were used for cannulation insertion site assessment. The hand hygiene was poor. In environment, the environment was overcrowded. Due to greater number of patients, the sinks were poorly located and there was limited space to prepare medications. All these factors led to poor adherence to asepsis during procedure of IV line insertion and maintenance and led to development of phlebitis and infiltration. Now this slide shows us some pre-assessment observations done by team members during the baseline phase. It includes keeping the syringes on the trolleys or on the chart or on the bed and the articles get contaminated that led to development of phlebitis. The possible interventions were entered in Eisenhower decision matrix. This matrix helps us select and prioritize the interventions or change by less efforts and high impact. In the figure, the interventions are categorized in 2 by 2 table on the basis of less or more effort required and the high or low impact each intervention has. We selected teaching the bundle and supplying innovative trays as our change based on less efforts and high impact. The outcome measure was the incidence of phlebitis and infiltration, and process measures included scoring on pre-validated checklist for intravenous line insertion and drug administration. In addition, the team also recorded opinion of healthcare professionals as balancing measure. Pre-assessment observations suggested that incidence of phlebitis and infiltration to be nearly 83 and 96% respectively, and intravenous line insertion and drug administration checklist scores as 8.69 to 43.4% and 20.58 to 41.17%, which means a reasonable scope of improvement. In this slide, we have depicted the PDSA-1. In PDSA-1, the sensitization of healthcare professionals was done through feedback of audit, pre-assessment, current practices and findings of focus group discussion. The planned interventions included aseptic intravenous line insertion and maintenance bundle. The bundle include use of ANTT and introduction of new cost-effective trays. This slide shows us the key steps in aseptic intravenous line insertion and maintenance bundle. There are 6 in number: strict adherence to hand hygiene, correct use of gloves, aseptic field management, that is to create a mobile sterile tray by cleaning it with 70% alcohol, use of transparent cannula to fix it, protection of key parts and key sites, that is hub of syringe, needles, ports of sterile equipments, cannula caps and hubs, etc. Keep all syringes in mobile sterile tray by closing the hub with needle and cap. Not touching the key parts or key sites. Disinfecting the key parts to prevent entry of harmful microorganisms. For example, scrub the hub with 70% alcohol and clean the skin properly. Here we can see the key steps being implemented using the ANTT practice. The first PDSA was followed by a series of 3 or more PDSA cycles in which the team first introduced stakeholders working in same area for monitoring insertions and training new residents and nurses who had joined. In the third PDSA, the infection control nurse took the responsibility to organize teaching program and coordinate with leader, executive and monitoring team. She also helped conduct regular data monitoring. Now coming on to the analysis. The incidence of development of infiltration and phlebitis decreased in subsequent PDSA cycles. The blue bar chart depicts the incidence of 0 to 48 hours and yellow ones depicts the incidence up to 72 hours. The incidence of infiltration and phlebitis was reduced from 82.96% to 45% and 96 to 0.9% to 55% respectively. The control charts were plotted for process measures and it was found that the scores gradually improved in each PDSA cycle. The scores for procedure of IV line insertion increased from 20.54 to 88.99%, and for administration of drugs through IV line it increased from 17 to 68.40%. So now the summary and conclusion. Adherence to steps of bundle, that is ANTT and new trays in an emergency department where the providers were absolutely resistant to change is a great achievement for team over a period of 2 months. Regular feedbacks from team members and the motivation of healthcare providers are helpful strategies. Also, the challenges of lack of resources can be overcome by low-cost local innovations. The aseptic IV line insertion and maintenance bundle need to be incorporated in the leading educational program and daily routine to achieve sustained benefits. It is replicable and with practice it will become a positive system change. So that's all for this presentation. Thank you.